get their care at the Lesion Clinic from Dr. Moschella and Dr. Ruiz here, as well as his colleague. So without further ado, let me introduce Dr. Moschella, who will be talking about clinical aspects of leprosy.
We're going to see sick people now. And this is a picture of Father Damien, and he's a champion for the underprivileged. As you know, he developed Leprosy leprosy and died at Kalapapa on an island of Molokai. And the reason I show this picture, not only for his compassion for the poor, he lived with the natives who had the disease in close contact. That's significant because if you're going to acquire this disease, you have to be in close contact over a sustained period of time. And it's interesting. Cabo, which is our national leprosy, for over 100 years, not one person working on the staff acquired leprosy. So the reason is, when they got through work, they went home. They didn't have this sustained, constant contact. The nuns were right into these people. The deep ulcers they were addressing. They were on monotherapy with cell phones, which is not that effective for controlling the disease as our multiple drug therapies that we do dispense today. So consequently, the importance of this individual shows and proves a point that it's close contact and sustained exposure acquired. Now let's get the story of how I got into the business. I was in the Navy and I was stationed at Guantanamo Bay, Cuba, and this is I got there in 1948, and I spent 3 years, and then I came back to the States, and they sent me back again for another 2 years, so I had 5 years in the area. And this individual was a maid working for a friend of mine, five houses down the road. There were 3 kids in the family. One day he brought her down in the Jeep to me, because I was a junior medical officer. Now, as a junior medical officer, you get all what the others don't want. There were 3 of us. There were 15 officers. There were all commanders and captains. But the guys that did all the work were the 3 JGs, myself and the 2 other guys. My job was a 60-bed medical ward. I had 2 years of medicine before I went down. I didn't have any dermatology. And my other job was to do pre-physicals. Before they employed Cubans, we used to do physical examination and all of them.
Yeah, I'm sorry. Let me just make sure we didn't loosen something up in all of this. Seems like it should be working.
Maybe on the screen.
I know.
That sounds loud. Hello? Hello?
It's the same word now.
I can't believe all of the technical.
Tell you how to get rid of this Moschella. Everything goes wrong. You know, next time we should have a special technician running the whole show. I don't think I'm going to do anything with this because it's not high. Can you hear me as well?
Yeah.
I hold this. Well, anyway, I was a junior medical officer. And we got what the others didn't want to do. In essence, I took care of the enlisted 60-bed ward. I didn't take care of the officers. I was in charge of the occupational therapy, occupational office. I did occupational medicine, pre-employment physicals. The idea was to keep these people at work as best you can. That meant you gave them medical attention unless they were sick enough and you had to send them home. And the third thing I had was I was also an early disease control officer. And that job had a certain responsibility. I was making sure that when the kids went on liberty, all the ships had penicillin, because at that time we were giving them oral penicillin to protect them from gonorrhea. And I don't think it could do anything for syphilis. Well, anyway, to make a long story short, I also was responsible indirectly for Caimanera, a town with 15 bars and about 150 prostitutes. And what we used to do is survey penicillin to the Cuban. There was a Cuban gunboat there. They had a couple of corpsmen on that Cuban corpsmen, and they would give the gals once a month IM penicillin. We didn't get any cases of gonorrhea, didn't get any cases of syphilis, but we did get chancroid. Because, as you know, chancroid responds only to sulfur erythromycin, but it doesn't do anything for a chancroid. Well, anyway, she showed in the office, and I was a internist, not a dermatologist, and I looked at her and I said, oh, this patient has angioedema. Maybe she ate something or got a drug and she blew up like this. Or she ate something she was allergic to. So what I did is I gave her some adrenaline, IM, nothing happened. So I decided to give adrenaline right into the lesion, and nothing happened. By that time, her blood pressure's going up, she's starting to shake. And my corpsman looks at me and says, you know, we can't give her any more adrenaline. No, I know. So that was about noon. And at noon, I usually went with a friend of mine who was an OB-GYN guy. And we used to go to the club for a sandwich and go for a swim. So he's in the Jeep, and he's yelling at me, come on, I got to get back. My clinic starts at 1. You're wasting time. I said, I don't know what the hell I got here. He says, oh, she's got leprosy. I said, come on, you're in the Jeep, you know what the hell leprosy is all about. So I told her, sit in the corner, I'll come back and do a biopsy. I came back from swimming, I did a biopsy, and sent it up to AFIP. And I get a telegram back from them. Please send us more tissue. This is an excellent case of leprosy in reaction. Well, okay. All things stop. This is the hospital where I was at. There's a new hospital now, but this is 1948. This is pre-Castro time. And this is where I had my clinic, where I saw everybody who were enlisted. And finally, I used to get my hair cut. And it was done by a Cuban. He was an intelligent guy. He was a school teacher. He used to come on the base on the weekend and cut hair. So I told him, I said, look, I got a case of leprosy. And what do I do with him? He says, well, this is Pedro. This is Jesus Pedro Couchet. Now, he is the Minister of Public Health in the province of Oriente. He had the responsibility of treating venereal disease. He had the serology lab, and he was also responsible for the team and the treatment of leprosy. So he made an arrangement for me to meet him. I met him, and I told him, look, I don't know anything about leprosy. Can I come and attend your clinic 1 day a week? So I got permission from my commanding officer, and 1 day a week I went and attended his clinic. There were 3 in his clinic with him. They saw 100 patients a day. Then he used to take me to the hospital, and the hospital had 450 patients. So the island of the province of Oriente was heavily endemic at that time for Hansen's disease. And that's my wife. We socialized. He was a great guy, but he was already in sympathy with Castro, I found out later. Now, recognize this patient. This patient has several messages to tell you. First, the nose is gone, the fingers are gone, and her eyes, unfortunately, are involved. And so this is the worst situation you can have. I mean, if you can't see and you can't feel, you've lost all your senses. It's like walking in the dark. You're blind, you can't feel anything. You know, I don't know how you can exist in that sensory deprivement. So if you meant the diagnosis of this disease, you have to have 3 things that you can appreciate. You have to appreciate if there's anesthesia, not the patient asleep, but the lesions are lacking in sensation. The second thing is you like to see enlarged nerves. There are very little conditions that will give you neural enlargement. Amyloidosis can do it, a few congenital diseases can do it. But in general, enlarged nerves are not part of any other disease that we have, other than those few exceptions I mentioned, but it is the characteristic finding that you have and see in patients with this disease. And last but not least is the demonstration of organisms. You either see these organisms by scraping the lesion, or you scrape the nasal cavity and you do a smear. Now, the WHO has a definition of leprosy. They say that the patient has to have white skin lesions or red skin lesions which are deprived of sensation. That's the first thing. Or you have to demonstrate damage to nerves as reflected in the hands and feet. And finally, positive smears. But the problem with positive smears in undeveloped countries where they don't have microscopes and they don't have technicians capable of interpreting these signs you can't do it that way. So this thing is out in undeveloped countries. The facilities are not there to do the research, to handle those kind of problems. Now this is a smear. This is what it looks like. These are rods. They are gram positive, but they're acid fast. And this is what he was telling you about when you heard the immune lecture. This is the patient this patient has globi. These are clusters of intracellular. These are macrophages, and these are loaded with these organisms. This is a patient who has lepromatous leprosy. This is the characteristic picture you see in the scraping in a patient with lepromatous leprosy. Now, if you're going to do leprosy, you better learn where the superficial nerves are. Remember, one of the characteristics about this organism, it likes cooler climate. And consequently, you can't find leprobacilli in the intestinal tract or in the ovaries. You'll find them in the male testicles. You'll find it in the anterior chamber of the eye, but not the posterior chamber. It's too long. You'll find organisms up to the larynx, but not below the larynx, because below the larynx, the body temperature and these organisms won't survive. And then the population of these organisms, they proliferate in areas that are cool. Elbows, the knees, the tops of the feet, the tops of the hands, the earlobes, and the nose. Those are the cooler parts of the body, and therefore there's a tendency for a greater population of these sites with these organisms. So this is a demonstration of enlarged nerves. These are cervical nerves, and they're all enlarged. They're like ropes. So you learn where these are. The cervical nerves, median and ulnar nerve, the median nerve here, the ulnar nerve here, the posterior tibial behind the fibula, the lateral sural nerve on the lateral ankle, the posterior tibial nerve in the medial malleolus area. And it's very interesting. Not only do these go to these sites, but these are tight sites. So if you get a nerve that's lodged in these tight sites that are superficial, and when they become inflamed, they swell. So what happens is you have a nerve being buried in a tight space. And that pressure, just that pressure alone, further contributes to the discomfort and the neural deficits that you appreciate later. And this is the lateral cervical nerve. So what do these nerves do to you? Well, the first thing is, this is described as a sensory sensation, motor, muscle involvement, peripheral neuropathy, because it's active, peripheral. The other thing is there's an autonomic component. In essence, there is another form of nerves that you have that are called the autonomic nerves. Now these control sweating. So when they are impaired, what happens? You see how dry those hands? They can't sweat. But if you look critically at this, you see the ulnar nerve involved. You can't flex that, you can't extend the small finger. Notice that. Also notice the thenar and hypothenar muscle. Look at your hand. And look at this nice swellings you have on the sides. Those muscles in your hand are normal. But look how flat this hand is. Look how flat this hand is. And notice the ulcerations, secondary to trauma or burns. So this is the classical hand of a patient with leprosy. Now, it's bilateral and symmetrical. That's important. Because when you get symmetry in like this, then you can damn bet sure that this patient has a lot of organisms that these patients can handle their infection, and they are of the lepromatous type. Now this is a patient, notice the clawing of the hands already? That's the motor component. Well, what's this? Patient can't feel heat, automatically puts her hand in hot water and she burns herself. So those are burns secondary to insensitivity to heat. So this demonstrates both autonomic, notice how dry the skin is, and notice the clawing of the hands. So this shows you the motor deficit and also the autonomic deficit, and the deficit in the capability of sweating. Now this shows you another thing. If you saw this patient in the States, you'd say the first thing, this patient probably has diabetes. But this, because diabetes is probably the prototype of this condition in our hemisphere in the United States. This is what is called a malum perforatum, a pressure ulcer. But also notice, not only is that there, but notice the toes. The toes are cocked, just like the hands. So this gal, this individual has motor involvement with caulking of her toes. And she has insensitivity because she can't feel any sensation. Well, how did this happen? She got a stone in her foot. She didn't know she had a stone in her foot. She can't feel it. She's pounding away on that. She gets home, she gets a bloody cut, and then she gets this progressive deformity here with ulceration. So, why all this? These are mitten hands and these kind of feet. These fingers are lost not because the leprosy destroys the finger. What happens to these people is they get secondary infection. They get osteomyelitis to other organisms, not the mycobacterial organism. And as a consequence, the secondary to the osteomyelitis, they lose their fingers. Now, this is what we see not infrequently. Unfortunately, I don't have the initial lesion. This youngster presented with a hypopigment. That's a white, slightly raised area on his face. He got a reaction, a reversal reaction from treatment. The problem with treatment is that sometimes you make the disease worse. Why is that? Remember that this disease has two consequences that are really a problem. You can beat the infection, but when you beat the infection, you destroy the organisms. Now, the body has a tough time clearing these organisms, and as a consequence, these organisms, broken down organisms, are circulating in your system. They become antigens, and the body builds antibodies, and as a consequence, if you get these antigens hitting T cells in patients that have borderline tuberculoid or borderline lipomas, they will get a reaction in the lesion itself. And as a consequence of the lesion itself, they'll get a paralysis, because if you got this involved, just imagine the facial nerve is going to be involved, because the facial nerve is right here. And as a consequence of that, you get this. This is the price you pay. So managing the disease is not that easy. Anytime I have a patient who has a plaque lesion on the face, whether she has paralysis or not, I automatically, while I'm treating them, put them on prednisone to prevent them from acquiring an underlying neuropathy that can result in either a lagophthalmos, you notice his eye, a lagophthalmos, the ophthalmic branch right there is gone. So she's got the facial, and then you got this, and as a consequence, can't close their eyes. Now, if they can't close their eyes, they get an exposure keratitis, but something gets in their eye, they can't get rid of it, and they get an exposure keratitis, which can scar the cornea and then get blindness. So the scarring of the cornea, the facial paralysis, all these are secondary. And the patient, it's tough. You have to tell the patients what they may happen. It's just a possibility of happening, because a lot of patients see what's going on and they don't want any treatment. They don't want to end up like this if they can help it. Not all the people end up this way, but we can't predict who will and who will not. And this shows the eye involvement. You know these little white areas? These are colonies of organisms. They get into the conjunctival nerves and they leave these little white dots. Now, if you go slit lamp looking, you can see these little white dots. And these are actually lesions in the eye. The eye gets all the same lesions that the skin gets, plus the reaction. And this is what happens when you get a reaction. This eye gets red. Notice the nice little round circle here is no longer round and nice. There's synechiae, there's fibrosis. The cornea connects to the iris, and you get this distortion of this aperture here. They can't react to light. Okay, you remember the immunology. You were told there were two types, a tuberculoid type and a Leprosy type. Tuberculoid type, characteristically, is what? They have good CMI. Their T cells, their CD4 cells, are very capable of turning on the macrophage to destroy the organism. So what happens here, if you get the disease, you're only going to limited asymmetrical involvement. You may have the associated nerve in that area involved, but that's it. You go to the other side. Remember he said there's no CD4 activity? These patients do, they just can't react to the organism. They can't even recognize it. They're called emergent. They have no energy to react to it. So their CD4 cells are making only IL-4, IL-5, IL-10, but they're making antibodies. The antibodies don't help you at all to fight this disease. You need CD4 cells, very active. turning on the macrophage to do its job. So this disease is widespread all over the skin and the anterior chamber of the eye. You do a biopsy anywhere in the skin, you're going to find organisms, whether you see lesions or not. Now, medicine is a funny business. Nothing's all white, nothing's all black. There's a gray area. And what do I mean? That's what the question I asked them. What is the immunology of patients with borderline tuberculosis? Those are patients who have a borderline tuberculosis here. Also referred by the English as dimorphous, but the Spanish called it limitante, borderline. Well, anyway, these people have more like tuberculosis, so they'll have more lesions than the tuberculoid has. And they'll have more neural involvement than the tuberculoid. As you go more towards this side, you now begin to get a more symmetrical, widespread involvement of the patient with this disease, both skin and nerve. What do I mean by that? Let's start with, this is what I call the chancre. You know, if you have syphilis, you have a chancre. And then everything, all hell breaks out later if you don't have any treatment. The same thing here. This is the chancre of leprosy. This is the indeterminate lesion. Now, dependent on their genetic makeup and their capacity to create a CMI, cell-mediated immunity, if they can't do cell-mediated immunity, you can predict what's going to happen to these people. They're going to go towards the lepromatous pole. However, if they have a strong CMI, they're going to hang around in the borderline or tuberculoid, tuberculoid. And now, remember, it's borderline tuberculoid or tuberculoid. Few organisms, if any, when you biopsy, they have a nice classical tuberculoid granuloma. Unfortunately, these like to get into the nerves early. They attack the nerves, they put the same granuloma on the skin inside the nerve. And therefore, patients with borderline tuberculoid have a more aggressive neural deficit created. In contrast to the lepromatous type, actually it just makes those nerves swell, but they don't put anything in it. Remember I told you where these nerves are sitting in tight spaces? When they swell, they literally strangle the nerve. So it's strangulation in the lepromatous type, but it's infiltration in the tuberculoid and the borderline tuberculoid. This is the classical tuberculoid lesion. A nice round granuloma, sitting pretty, all by itself. It may have a little nerve, but you touch this with a pin, you will feel it. You put cold water on it, won't feel it. Put hot water on it, won't feel it. There's what is called dysesthesia. Remember, there are three sensations. There's pain, there's temperature, and there's cold. You may have one, you may lose two sensations, or you may lose all three. And if you're not sure, what you do is you get a little histamine. You put it in the skin. Now, histamine makes a wheel. And then the wheel raises, and then there's a surrounding erythema. A reflex erythema occurs. Patients with leprosy don't have that reflex erythema. All they have is a red spot with no flare. This is a very interesting story. This is grandma, and this is her grandson. Her son is in the Navy. He was a Filipino fellow stationed in Philadelphia on ship. Mother was in the hospital with fever of unknown origin. And then they asked me to see in consultation. And the mother had these red lumps on her feet and her arms. And her mother had a reaction to leprosy called erythema nodosa. We'll talk about it a little later. If you look at grandma, you'll notice she had no eyebrows. You notice these red bumps. These are erythema nodosa lesions. This is the immune reaction in a patient with lepromatous leprosy. It's caused by immune complexes. Remember, they make all kinds of B cells, make all kinds of proteins, and they make all kinds of antibodies. A perfect setup for an antibody complex to come into play and giving you this immunological response. But interesting, the child has the ocular lesions with no demonstrated organisms. And this is borderline tuberculosis. Child, grandma has non-reactive lepromatous leprosy, and mommy's in the hospital with acute reaction, ENL, erythema nodosum. That's a nice name, erythema nodosum. Nodules, red nodules for the patient with leprosy. Now you're seeing what happens. These lesions like to be ocular. This arcuate means these circular ones. Now notice that this is more symmetrical and widespread. Notice the hand here. So this is a patient with borderline tuberculoid, almost in the middle of that circle I showed you, that little curve. Now we're getting more aggressive. Now we're beginning to see not only arcuate lesions, but we're beginning to see nodules. Now we're more in the borderline lepromatous. Notice how widespread this is. So the pattern which you see can almost predictably tell you what you have. Notice the mid-back is pretty much spared, but as you get toward the lepromatous phase, you don't have this respect for the cooler parts of the body. Now these are what we describe as tumid lesions. So you can anticipate when you get this kind of response, there must be a lot of bacilli there to create this kind of reaction pattern. This is a patient with borderline lepromatous. So you see few lesions, more lesions, to nodules and more lesions, symmetry, and the same thing applies to the neuropathy. Now this is a patient just who has borderline lepromatous, more widespread, non-reactive disease, more generalized. If you look at this individual, you might pass him off as having nothing. But if you look closely, notice that skin is totally infiltrated. Notice the absence of eyebrows, no eyelashes. Notice the earlobes tend to be more pendulous. And notice a little drooping here on the side. This patient has diffuse lepromatous leprosy. You can have this phenomenon. It can look like a patient with scleroderma, myxedema. Could look just like this, except his tongue is going to be swollen, isn't going to be swollen. So these are the patients who have later on a little phenomenon I'm going to talk to you about. Now this is the classical presentation of Fan's case of lepromatous neck. You can predict, as I say, where will you see these nodules? Cooler parts of the ear, the nose, the forehead. This is a patient with nodular lepromatous leprosy. This is the kind of picture you see when somebody in the textbooks wants to write about leprosy. Now, this is the so-called leonine facies that you see. This is either further advanced, this diffuse infiltration, not only into the skin, but also right into the fat. Now we talk about reaction. Now, if you're going to have a reaction, there's two types, type 1 and there's type 2. The reason it's called type 1, because type 1 patients have enough of that immunity with the CD4 cells that they will develop this kind of reaction. The cell-mediated response to these individuals are comparatively and relatively intact. So their challenge when they get the reaction, when they have T cells moving around, they're not making any antibodies like the B cells, like you see in lepromatous cells. These people don't make that many antibodies, but they do make their antigens are picked up by the CD4 cells, and they turn on the CD4 cells. The CD4 cells release cytokines. Now, cytokines, as you know, are kind of material that gets into tissue and does a job. Now, these cytokines can create inflammation. And so what happens is you have a lesion, patient's being treated, doing well, all of a sudden he comes to you and says, gee, look, doctor, I'm getting worse. You say to him, no, you're not getting worse. The medicine is killing these lesions, these bugs, and you're getting better. And if you want to know if a drug's working, if you see a reaction, then you know you got something going on, because you wouldn't get a reaction unless the drug was efficient. Now, you can see another patient with borderline tuberculoid disease. There were flat lesions, all of a sudden they explode into these edematous lesions because those T cells are releasing cytokines that create tissue damage and injury in the form of inflammation. Notice how red and inflamed these can be. They weren't that red and inflamed previously. They can also go on to ulceration. And these are the bullous lesions that you sometimes can get only in the sites where you have these lesions, because they're the only sites that have the bacilli. Remember I told you, lepromatous leprosy, you can biopsy any part of the body because they are allergic. Here, their CME is so good that it just grabs those organisms, holds them there so they can't go elsewhere. They'll stay in the nerves and they'll give you damage there as well as the skin when you react. Okay, let's go to another shift now. Now I'm going to talk to you what happens in patients. Remember he said it's the graphic picture he showed, the graphic picture, he said you can forget the right and you can forget the left. Well, you can forget the right here, the CMI, and now you're only going to think about the left, which is non-cell mediated. And these people who are deficient overreact making B cells. When they overreact making B cells, they'll make antibodies such as rheumatoid factor, positive serology for syphilis, false negative for lupus. All those antibodies, you can find those in the peripheral blood if you look for them. Because these B cells are so turned on, they're making all kinds of antibodies. Now this gal came from Bedford, New Bedford. You know, New Bedford is a fishing town, as you read in the old days, and most of these were Portuguese people coming from the African islands. And so she was down there, and she was being treated by a dermatologist for acne. And finally, he decided that, you know, he didn't know really for sure, so he said it to me in a consultation. Well, I just looked at her, my God, these are all nodules. Notice that she had minimum expression of the disease. Her eyebrows are intact. She had no problem sweating. She had no neuropathy. The only thing she had was recurrent epistaxis. Remember, with the nasal involvement, and particularly lepromatous leprosy, recurrent epistaxis, not infrequent. They get a leprous rhinitis. I've seen a couple of cases that I saw, and rhinopathies were done on patients with lepromatous leprosy, and the tissue was just discarded, not even sent to the lab. And those patients with this kind of diffuse lepromatous leprosy, diagnosis was missed. Now, recognizing that these are neutrophils, and neutrophils come to the tissue. Remember, the response in cell-mediated type 1 is lymphocyte-driven. However, in patients with lepromatous type of leprosy, it's neutrophil-driven. Neutrophils make abscesses. Neutrophil makes collections in skin. It causes inflammation. Neutrophils can cause paniculitis, that is inflammation of the skin. You don't get vasculitis. For some reason or other, there is an immigration by these cells into tissue. I assume that something, an antibody, gets into tissue because it creates this phenomenon. Neutrophils release proteases, and proteases can destroy urinate and create problems. So you may see a patient present with pustule lesions like this in a patient with erythema nodosum leprosum who has lepromatous leprosy. Oops. This is a patient, another patient I saw, and of course at the hospital in Philadelphia. It was referred to me by a physician in the main line. He had a maid from Philippines who presented with these kind of edge cuts. And notice the cigarette healing. Oops. And this is what the maid looked like. Notice the eyebrows lost. Diffuse infiltration. This is the so-called Benita type of leprosy. Now, it's mainly from Mexico, in a province around Guadalajara. It is not infrequently seen down there. So these people get into Southern California, and most of the cases we see in Chicago are referred from that area, Southern California, who are Mexicans. This is unusual that it occurs in the Philippines. There are sporadic reports occurring in Brazil, in Mexico, in the Philippines in particular. Now, this is her picture. So this is a special form of erythema nodosum-like. We don't know what the mechanism is here. If you look in these patients' biopsies, you'll find the lining of the blood vessel just loaded with bacilli. And there tends to be a proliferation of the lining of the blood vessels in response. And as a consequence, this load of proliferations of the lining of the blood vessel creates ischemia. Ischemia means deprivation of blood to the tissues. And as a result of this deprivation, you've got this necrotic tissue. And when it heals, the patient was said to me as, quote, ecthyma. I don't know if you know what ecthyma is. Ecthyma is a form of impetigo, like they get blisters and they get vegetative lesions secondary to the bacterial infection. This is the result of obliteration of the blood vessel by an endothelial proliferation associated with great numbers of bacilli choking the vessel in the endothelium. This is an advanced case of it from Mexico. Notice the characteristics. Remember I told you about the epistaxis. This type of disease has a propensity to destroy the nose and the cartilage. It's very characteristic. They don't tend to get much ocular involvement. They don't get too much peripheral nerve involvement, but they get significant ulceration and destruction of tissue. As a consequence, they're on high doses of steroids. They're a perfect setup for secondary infection. A lot of these people die with gram-negative septicemia. Now, this patient here, this is ancient history. Okay, what about treatment? Well, the WHO was cute to say they don't follow the Ridley-Joplin classification, which is based on an immunologic status. That curve I showed you, the LL, the TT, the tuberculoid, the lepromas, the borderline, they don't follow that. What the WHO said this: we don't want to do smears. We can't do smears. It's very difficult to classify these papers, because when you classify with the Ridley-Joplin, you have to know what the BI is, the number of organisms there. You have to know what the immunologic status of the individual. You have to understand what the clinical presentation. It's a correlation of those characteristics of the patient. You have to have the laboratory substantiation with the clinical substantiation to make a classification in the Ridley-Joplin. Too complicated for the technician in the field in an undeveloped country. We've got to make it easier. So here's what they said. If the patient has one lesion, it's described as a single lesion, single paucibacillary. Pauci means few, if any, and multibacillary means many. The assumption is that the organisms are going to be there, although they don't see them under the microscope. And this is the single lesion, okay? Now, the paucibacillary is where they use a count. If the patient has 5 or less lesions, they count the lesions. They're considered paucibacillary. If they have more than 5 lesions, they're multibacillary. Okay. Now, if you want to treat them, it's very simple. You give them a card. On the card is the pills that they have to take. So if you have single lesion, they give you one card with 3 pills on it. And the pill is 1 rifampin, 1 ofoxacin, and 1 minocycline. And that's the dosage. 1 dose, and that's it. You've been treated. Forget it. Don't bother us unless you get more skin lesions. Now, if you're paucibacillary, you get 2 drugs. You get a card with 2 drugs. One is rifampin, and the other one is Dapsone. And you do it for 6 cycles in 9 months. But Carvel doesn't believe in that. You've got to have it for at least a year. And you've got to have your rifampin, not once a month, but every day. We can afford it in our country. A lot of undeveloped countries, that's even a problem. As was pointed out to you, it's the socioeconomics. There are other things that they're worried about. They're worried about malaria. They're worried about TB. And in the profile, few crumbs drop from the table for the patients with leprosy, unfortunately. In multibacillary, they learned that you can't treat this disease with monotherapy. Like TB, you get resistance. It took them a long time to understand that. It used to drive me crazy when I went down. This came about because Shepard developed a foot pad in the mouse. And he found that 25 milligrams of Dapsone was enough to control the disease in the mouse. So he projected that in. He said, we were giving them too much Dapsone. Let's cut the dose 50 milligrams. And if they had a reaction, you knew if you stopped the drug, the reaction would clear up. But then when you put them back on the drug, the reaction would recur. In essence, that misled us. And then we discovered that there was resistance developing. You had to have more drugs than one. Carvel recognized that and put the patients on rifampin for the first time. And the beauty about rifampin is bactericidal. If you take rifampin with another like Dapsone and clofazimine, for example, you're sterile. You can't transmit the disease. You can't get your viable organisms out of you after a week. So it's a perfect setup for minimizing transmission of the disease. So that's the status of the art right now. There are a few experimental programs going on, but I don't want to bore you with that. What do you think this might represent? Our colleague told you about that. Yeah, that's clofazimine. And look where the distribution is. Why do you think the distribution is like this? What is clofazimine? It's a dye. It's a lipophilic dye, right? Organisms, where are the organisms greatest? Cooler parts, the nose, the forehead, and the ears. So the intensity of discoloration is going to be highest there because the dye has an affinity for the organism. If you heard when the immunologist spoke to you, he says one of the problems, one of the things about the bacillus, it's rich in lipoproteins and waxes. And as a consequence, those are drugs, those are areas in which this drug has an affinity to get to and creates this discoloration. Minocycline also is used in case of discoloration. This is the administration house in Carville, and this is the late John, well not late, he was the retired Admiral John Trump. This is what you see in the picture of Carville. This is the armadillo, ring, 9-ring. And what about the ambulatory care program? Oh my God. The ambulatory care program, let's see, who's eligible for it? Any person living in the United States, Puerto Rico, or Territory can, by law, receive outpatient medical care for the diagnosis and treatment of Hansen's disease. But if they have any other diseases, unless they're covered by insurance, they get free health care. The reason they get free health care is to try to get them to get in with the program, to maintain themselves on treatments, and encourage cooperation between the patient and the physician. Now there are two methods of methodologies to treat the patient. Before I get into that, I've got to recognize that Carmel was an expensive operation. The government realized that they shouldn't spend $6 to $10 million a year to run a place where they had actually outpatients living in-house. It was like a nursing home, and then the periodic appearances of patients only for 4 days, and they were sent back to their family doctors. It was an expensive proposition, so the government decided to create satellite clinics and also to get doctors who might be interested in the United States in handling the disease. And they did that. They established outpatient clinics. They did a private physician program. Now, these are the outpatient clinics in the country. Boston, Miami, Chicago. All these are outpatient sites. You can get treatment there free, and medicine's free, and all the other problems are fine, prosthesis and otherwise. What can you get? Medical services, as I talked to you about, nurse services, diagnosis, tests, x-rays, eye surgery, reconstructive surgery, creating situations that you can better utilize your hands and your feet, patient education. And this is the numbers of patients per clinic, roughly. The numbers have changed a little bit. These are active patients right now. I would say that there's probably about 5,000 patients. But remember this, once they're treated, the WHO likes to believe that they've been cured. So all over the world, the prevalence rate has gone down. But you know, the numbers of patients have gone up, the new cases. And so this miracle with the multiple drugs is not really a miracle. It's reducing what's allowed those countries to say to the governments, oh, you know, we don't need that much money anymore. We'll cut our patient load down. We don't have 10,000 patients. We only have 5,000. But the problem is, these people have to get through treatment, get continued reactions. They've got visual problems, they've got hand and feet problems. They're the socioeconomic liability. They can't get jobs. They need health care. To try them to get jobs, you've got to fix them up in a way that they can function effectively. So now the private physicians. Private physicians get free meds. They get consultation with Baton Rouge, where there's Summit Hospital down there, which is a new mother house. They process biopsies for them, the skin smears, you can make smears and send it down to Baton Rouge, and they'll interpret it for you. All those are relevant to you. Now, these are the physicians in respective states. There are 333 physicians who are signed with their public health service, the fact that they are competent, capable, and interested in handling this disease. Because if you remember, all of us clinics are in the periphery, other than Chicago. And there's the, you know, it's the middle part of the country that needs help. Now, outpatients, according to private physicians, are treated 327, and totals about 3,000. But the numbers are larger than that because of age. In the United States, we just don't disband these patients. They belong to us. I have about 75 active, but I have about 180 patients who I see continuously. I always inspect their hands and feet. I check their eyes periodically. I keep reminding them if they get a reaction, come back and see me. And they're not done, but they're a chronic problem. The seriously involved patients who just can't come loose. A figure I would say would be 10 years of follow-up minimum. That should be it, 10 years of follow-up. And a good lady here, God bless her. Thank you.
Do we have any questions for Dr. Moschella? He will be leaving shortly, so we may take the opportunity here. Jose?
Just one. As recently as last year, Dr. Jacobson told me that the only group in the U.S. that has not been diagnosed with HD was the Native American. Is that still true?
I gather it is. You know, there are a lot of things that are written in the literature that I'm not sure of. Because if you go to Mexico, Indians down there get it. Why should the American Indians be so privileged? I mean, I'm not sure. I have not seen them, frankly. I don't think they have seen them down in Canada. But that doesn't mean it doesn't exist. I don't know.
Other questions? Thank you very much. That was fantastic.